So in making all those decisions, we need to understand the person's physical, cognitive perceptual levels, as well as how they do taking care of their basic needs, such as dressing, feeding, toileting, grooming, bathing, and medication management. So we look at measurements and outcomes. And when I consider which measurement tool to use, I think of a couple of things. I think of how long will the assessment take me to give? If the person is acutely ill and probably going to get better quickly, then I don't want an extensive assessment that's going to cost a lot of money. I want something that will help me decide, can they return home? Do they need to go to a subacute rehab that's based in a skilled nursing facility for a while? Or are they now going to transition into some sort of senior living environment? If, on the other hand, I'm going to have a person in that subacute rehab or rehab situation, I may want a measure that's a little bit more accurate to change so that I can see how the person is doing today, but I can also use it for reassessments along the way to help the person qualify for additional insurance coverage for their rehab needs. When I talk about activities of daily living, they can include dressing, eating and feeding, toileting, bowel and bladder management, bathing or showering, personal grooming and hygiene, sleep and rest, and functional mobility. When I talk about instrumental activities of daily living, I'm now talking about a person's ability to manage their finances, prepare a meal, manage their medication, being able to utilize transportation, being able to shop for the food or medication they might need, their use of a telephone, and many, many more. So the instrumental activities of daily living are beyond the basic self-cares that someone with more cognitive or perceptual challenges may have a more difficult time performing. So I can look at different assessment tools. The modified Barthel assessment is an assessment of functional independence in the domains of personal care. So those very basics, dressing, feeding, grooming, bathing, and mobility. The nice thing is that it is a quick assessment. It only takes between 5 and 20 minutes, while it yet looks at 10 different personal care activities and helps me determine if a person can go home independently, go home with support, or if they're dependent for various activities, in which case they still might be able to go home, but with more support, or they may choose to go to a different facility. Talking about direct assessment of functional status. And that is where there's a observation-based checklist. And the purpose of this is to assess functional capacities of persons with cognitive deficits and have been used to indicate the severity of Alzheimer's disease process. So it may be used for evaluation and reevaluation to assess decline in function and to evaluate the effectiveness of pharmaceutical interventions on functional status. We use this on adults with Alzheimer's disease and different dementias, as well as older clients who also have schizophrenia. The CATS Index of Activities of Daily Living, again, is a relatively quick, easy to administer activities of daily living assessment that indicates the level of independence and the type of assistance an individual would need to carry out the activity. Because it's general, it is useful as a screening instrument for communicating the general patient function and again, developing a care plan and specifically discharge plans. How much help will that person need? We usually administer it to older adults and those who are chronically ill. The kitchen task assessment was developed to practice an objective measure of organizational, planning, and judgment skills as performed in a common food preparation task. It provides information on the level of assistance necessary to support such performance, as well as recording change in the subject's function over time. It is used with individuals with various dementias and Alzheimer's. The Coleman evaluation of living skills, again, is an observational-based assessment that's quick and simple evaluation of a person's ability to perform basic living skills, and it can help determine the degree of a client's independence and suggest appropriate living situations that will maximize independence. So again, trying to help us make a decision based on evidence of the least restrictive environment an individual can age in. It's been developed to use on patients with short-term psychiatric challenges of the American culture, and it's a wider application. It includes clients who are mentally retarded, geriatric patients, brain injured, or cognitively impaired. Another assessment that I think offers a lot of good data for us to use is the Performance Assessment of Self-Care Skills, or the PASS. The purpose of this assessment is to provide data about daily living skills performance in a clinic or in a home. It establishes baseline functional status, and it measures change over time and at time of discharge, and it again assists in treatment and discharge planning by identifying the type and amount of assistance required for successful performance. It's used with adult populations in the clinic and at home. So the PASS, again, has 26 different tasks embedded in it, and one of the tasks that it looks at is medication management. Every task, the 26 tasks, can be given individually as standalone, or you can give a variety of the tasks over time. Fall risk assessment is another aspect we need to consider when deciding the least restrictive environment where the person can lead a productive and safe life. So all older adults should be receiving a fall risk assessment when they see their primary care physician. And the two quickest ones to administer are the functional reach test and the timed up and go test. Both have standards that are both age-based. The other thing is, after an individual sustains a fall, it's very important to conduct a thorough interview to determine the factors that caused it in a way to try to prevent it from happening again. So I can give you an example where recently an older gentleman who lives in assisted living in his own apartment and is quite private doesn't come out of his apartment very much anymore. He used to come out for 2 meals a day as well as attend various group activities. He liked bingo, he liked evening movies, he liked a lot of the musical performances. But over time, as his mobility has become more challenging, he's also chosen to self-isolate as a way not to fall. It then became known that he fell in his apartment twice before telling somebody, his daughter, on the third fall. And both those times he fell while getting out of bed and going to the bathroom at night. He had many explanations for his falls, including saying that the bedding was sliding off the bed at night. But one of the other things I worked with him on was the fact that the environment, when he got out of the bed, there was a chair in the way from his bedroom to the bathroom, and so that increased, his ability to have to move around it at night when he was not fully awake, which increased his fall risk. I also found out over time that because his ankle was bothering him and it kept him up at night, he was often taking Tylenol PM, which makes you drowsy, which doesn't help when he gets up and goes to the bathroom. So assessing his fall risk was important to document that indeed he was an increased fall risk so that I could sort of explain that to him, and then treating him appropriately. And in his treatment plan, I worked on strengthening his lower extremities, I worked on his balance, and we also made environmental adaptations, including moving furniture out of the way, as well as he is now using an assistive device to walk. And here are just some very simple references that are good to go to if you're looking for any of these assessments or more information about aging in place safely. Thank you.